Well, good evening, ladies and gentlemen. I really appreciate you making time after a long day of ASCO to sit with us through really exciting talks defining a catalyst for the redefined care in colon cancer. I would like to welcome you on behalf of Sarah Lonardi and Kathy Eng. These are world experts on precision care in oncology, so you will enjoy their presentation. There is no doubt about it. So before we go to the normal welcome, I would like to tell you a joke, okay? Because we're all tired also, let's take it easy. So a little bird flew from the north to the south because this bird wanted to escape the cold. But unfortunately, the bird hit a cold front, froze, and fall down on a field. A cow came by and dropped a big pile of dung on this little bird. And after a couple of minutes, the bird was thinking, I'm getting warm, and was getting really happy and started zipping, okay? A cat close by heard the bird zipping and came and got the bird and ate it up. So what's the morale of this story? Not everyone who shits on you is your enemy. Not everyone who gets you out of shit is your friend. And when you're in deep shit, shut your mouth. Okay. So let's go to the welcome. We would like to thank, of course, Peer Review, who organized this wonderful meeting in this beautiful hotel, and the Colorectal Cancer Alliance for providing the session, and BMS and GSK for providing the educational grants to make sure we can pay for the symposium. If you haven't already, please complete the pre-event survey and look out for additional polling during the presentation. We will have some polling questions, and I would love that you participate. If you have any questions during the lectures, just ask us. We are all friends together here. You can also submit your question if you're a little bit shy through the polling system, or can ask your question during QA session. In-room learners, your personal device, you can scan the QR code on the following slides to respond to the polls and ask the faculty questions. Virtual learners, please respond to the polls on your screen and enter the questions in the chat window. We can see the questions on our iPads.
Where did she go?
So here, when you get actually rewarded, you have a chance to win $50 gift cards. I think 2 of them or 1 of them, I don't know. The one who wins pays for the rest of us. So just download it that you have a chance to win a gift card. Next one. So there is more information. You can actually look at the slides and practice aids, and you can download them from the QR code. Just visit the website peerview.com 2025 CRC. So what are our goals today? Well, we want to enhance our knowledge of molecular testing recommendations and the latest clinical trial data supporting the use of immunotherapy platforms for colorectal cancer. And I will show you some of the slides we presented today in the oral sessions a few hours ago. We want to equip you with the skills to personalize treatment plans for your patients with colorectal cancer and provide you with tools to manage practical aspects of care using team-based approach. We will also learn, which I found extremely interesting from Sarah, how to manage some of the side effects of immunotherapies, which sometimes can be tricky. Next one. So this is our agenda. We have seminar and tumor board sessions. We facilitate prompt intervention in metastatic colorectal cancer. We will show you a case. We will show you some background information on colorectal cancer, immunotherapy, as well as neoadjuvant approach for rectal cancer, and how to deal with potential side effects of immunotherapy. Next one. Okay, now we are starting with the presentations. Kathy and Sarah, you want to introduce yourself?
Sure. Kathy Eng from Vanderbilt Ingram Cancer Center.
And I'm Eng Lonardi from the Veneto Institute of Oncology in Padova, Italy.
Okay, so I want to really address the barriers why some oncologists are not using molecular testing. The next slide. We have seen from many databases that only about half of the patients really get molecular testing done for genetic changes which can or are actionable. And we just heard in the oral session the new data on breakwater in the first line with encorafenib, cetuximab, FOLFOX. The data are amazing. Median survival of 30 months. So you need to know BRAF in order to make sure your patients live 30 months instead of 12 or 13. You can see data here on KRAS, on BRAF, and MSI high. HER2 was not included, and it's about 50–60%. Just not enough in order to make nowadays treatment recommendation using EGF receptor inhibitors, BRAF inhibitors, or immunotherapy, which are all now in first-line treatment, including the HER2-targeted agents, which are in still clinical trial with the Mountaineer. Next one. Now, you can already know prediction and prognostic of colon cancer just knowing where the primary tumor location is. And it's a funny story. This actually was developed and identified in my laboratory. And the reason is we worked with an epidemiologist who told me that colon cancer is very low in premenopausal women because estrogen protects. But estrogen is only expressed in the right side of the colon. This is basically area of the arterial mesenteric superior. So the hemicolectomy is usually done 2/3 of the transversus and the right colon. So from then on, we looked for ER-beta expression in colon, and we were the first publication in JCO. I was shocked they took it. Look at ER-beta prognostic in colon cancer, and it was highly prognostic. Postmenopausal women have more colon cancer than breast cancer. So just be aware of it. Now, because of this location, we started doing all our biomarker research adjusting for the location of the primary tumor and found many differences, including the EGF receptor, including the FIRE3 and 80405 data, which turned out to be, when you're right-sided, you do not benefit from EGF receptor inhibitors, independent of the VAS status. And even on the right side, the prognosis, as you know, is about half than the rest of colon cancers. There is big differences. The worst is actually on the hepatic flexure, the 1.98. No one knows why it's worse than the rest of the right side, but it's very, very unique. And no one knows. It's not genetic because there are no significant genetic differences. In this process, we also looked at the frequency of colon cancer in the transversus colon, which is extremely low. So no one understands why the epidemiology of colon cancer has low frequency of transversus colon cancer, but a lot of on the left and a lot of on the right. But the middle is often spared. There were only 9% of transversus colon cancer in major clinical trial studies. We have no idea why. Next one. So what is the minimum you have to test your patients for? We all know the KRAS mutations, which not only is predictive and prognostic, now with a specific inhibitor of G12C and novel treatment option with developing with G12D, vaccine programs, RNA-based vaccines, you need to know. And now I have to change of most in the dictation. When we said a couple of years ago KRAS mutant, now I have to put in what is the specific mutation. The BRAF mutation, you already know, the V600E is significant prognostic, poor, half of the life survival than the rest. This can be completely reversed when you use BRAF inhibitors, cetuximab, and chemo. Now, BRAF mutant are important because the clinical course is completely different. They have very unusual metastatic sites, peritoneal, bone, brain lesions. When a BRAF mutant patient comes to me and says, has headache since 2 weeks, I do an MRI of the brain. Others, I give an ibuprofen. So it will change the way you look at patients and monitor and screen. MSI high is an absolutely must, because with a new immunotherapy, I will show you, we cure many of these patients which were not curable. HER2 amplification, we have new treatment options. You know, there are new treatments approved. We will not talk too much tonight about it, but we have tucatinib and trastuzumab, and we have TTXD. So 2 treatment options, not in first line, but in second line. Both are actually tested in first line. So this is the minimum. The easiest is to just get an NGS panel if your insurance or when the patient allows that. Next one. What has been a big awakening is when you look at any clinical trial for MSI high, doesn't matter what company sponsored it, between 10 and 20% of the MSI testing locally were done wrong. They could not be centrally confirmed. And it has to do, of course, with the testing laboratory, the testing kits, and the experience of this laboratory. Okay. So it's always safe to make sure you have a reliable pathology lab who is familiar with the testing, and if not, do also an NGS testing, which usually use PCR-based technologies. So I always do both, just to be sure. Now, some of the mutations, as you know, when you send out for NGS, it takes 2 or 3 weeks, too long for newly diagnosed. I send out a liquid biopsy to get back in 5 to 8 days, that I make the right treatment decision. Next one. So that was actually the hint that we not need necessary tissue. It has probably more coverage, but for the liquid biopsy, you get up to 700 genes, mutations, tested, all the ones needed to make a decision of first line. Now, I repeat liquid biopsy at the time of progression because you can gain and you can lose mutations which impact treatment strategies. You know the word rechallenging. That is actually a reason for loss or gain of mutations where you can make regaining or rechallenging with the treatment you have done in the past. Next one. There are a lot of resources, and if you have time, please download that. This is from the Colorectal Cancer Alliance, and there are information for patients explaining, because the patient engagement in molecular testing is not easy, because it's very confusing to talk about NGS testing, liquid biopsy, germline testing, and they always mix it up. So it takes time for them to understand, and some of these educational resources are very helpful with that. Next one. So this is our first patient for today. So this is James, a 57-year-old patient, presents with a newly diagnosed cecal colorectal cancer with mets to the liver. You can see on the left-hand side, this is the blood counts. The CBC is okay, a little bit low, slight anemic. Platelets are okay, normal bilirubin, normal creatinine, and the guy is in really good shape. So what do we need to know? So what are the first steps in evaluating James for therapy selection? How would you approach baseline tumor assessment in the best quality of care? And what biomarkers should the care team be prepared to test with the diagnosis? Okay, so let's get to the first polling question. So which of the following molecular tests would you now order for a patient with newly diagnosed metastatic colorectal cancer? And you can code this, and you have the answers: only NGS, only immunohistochemistry for mismatch repair, only MSI, MSS status by PCR or NGS, both immunohistochemistry and PCR, or I would not perform any molecular testing unless the disease is progressing. So you guys now vote, please. You can vote. You know the answer, okay? Okay, we have the results. Both MMR and MSI testing for the PCR, 76%. Now, I need to talk to the person who said I would not perform molecular testing with disease progression. And the other one are very few. So I think there is not really a wrong answer except the last one. I think it would be probably good to have an NGS panel, but we need to know for sure MSI. And either test is fine, either the protein with immunohistochemistry or the PCR with the repeats. Okay. Kathy, what would have you done?
Sorry.
Are you paying attention?
We had a microphone issue and I wasn't paying attention.
Okay, what orders, test do you order in a newly diagnosed metastatic right-sided colon cancer?
Always MSI and NGS.
Okay. Sarah?
In our practice in Europe, we mainly perform IAC, immunohistochemistry, in all the colorectal cancer diagnoses, every stage, because also for the Lynch syndrome universal screening. And we do perform PCR or NGS only in the cases that are a bit shaky, like, if you have PMS2 isolated loss or MSH6 loss. If you have only one protein lacking, is always a bit suspicious. Yes. Or if you have a couple lacking and the other one undetermined, it means that the sample is not so good for immunohistochemistry. And so in those cases, we perform both the tests, but not routinely for all the patients, because also, well, there is a constraint of time, resources, and so we select the cases in which to perform both the tests.
Yeah.
So I think MSI high is a very unique biomarker, because in stage 1, it's very good prognosis. In stage 2, it's very good prognosis. In stage 3, not prognostic at all. And in stage 4, it is poor prognosis. So how can one marker be very good, indeterminate, and very poor? Anyone has an idea how is that possible? Because the mutation going along with MSI high are not random. Mutations who are metastatic are very aggressive mutations with proliferation metastatic processes. And in stage 2, there are actually mutations which prevent metastatic disease. You don't find this mutation in stage 3 or 4. So it's very unique. There is not a random association of mutations in this microsatellite unstable tumor. And I agree with Sarah, we do immunohistochemistry on all patients because of that potential prognostic effect. Because in stage 2 with MSI high, do not do any chemotherapy. Right. And the MSI high tumors, which are T4, are the football-sized tumors with no lymph node metastases. That's unique for T4 MSI high tumor. So it's very important to add that to your risk, because clinically it looks like it's a high risk for tumor recurrence, but it may be not. Okay, let's start with the first presentation.
Actually, Heinz, I was just going to say, do you want to emphasize when you would do the PCR testing?
Okay.
Because it captures that 10%, just so it's for clarification.
So actually, I do both. I always do NGS and mismatch repair by immunohistochemistry in order to be safe, because I want to see also the mutation spectrum on that. So I do both.
Okay.
Okay. Now, Kathy and I, we were a little bit surprised when we looked at the NCC guidelines for immune checkpoint inhibitors in any lines of MSI high or mismatch repair deficient metastatic colorectal cancer. Because there are many immune checkpoint inhibitors approved. We often very well aware with the Nivo, the Ipi, with the Pembro, with the Dostarlimab, but the other ones are getting a little bit less known. But they're all approved, or recommended, I shouldn't say approved. Now, what I was shocked, and I did not realize, there is even Nivo-Ipi recommended in the NCC guidelines after prior immunotherapy. That is interesting. I was not aware of it, and my fellows bring me the guidelines every single day. So I think that Kathy will go into the guidelines, particularly when it's in a neoadjuvant setting, which look very interesting. Okay, I'm sure the European guidelines has not this kind of.
We were just making a face just now.
Yeah, it's like I was very surprised. Okay, so I think I mentioned that be aware where you get your MSI testing done. This is from Checkmate 8HW. You can see between 19 and almost 20%, 10 to 20% are misclassified. Now, Checkmate was a global study, so the different testing labs were around different hospitals, different countries, where the standards may be not always the same, but a lot of these tumors may be misclassified. So that's the reason I always do two, okay? Now, in the central testing, when mismatch repair was missing, like both proteins, they called it MSI high. But if it's shaky and there's only a few proteins lacking and not the others, always do the PCR or NGS testing. Just be aware where you send it. And there can be false readings or false positivities, also the other direction, because certain genetic variations can impact function, but remain immunogenicity to the antibody, okay? Now, the biggest mistake is done when you do NGS and you're doing MSI. If the tumor content is less than 20% of the tissue, you may read it as MSS, but it's MSI high. So that's always an important when the pathologist collects and selects the slides for sending, that he does that. So we had recently a patient which was misqualified or saying MSS. I got the protein testing which was missing. I had to go back, and the slides were sent from an outside hospital. I don't think it was quality assured that the right tissue section was sent. Just be aware of it. Now, we have clinical and molecular predictive and prognostic markers. And one of them, which became very clear over the last couple of years, is that we know liver metastases do not respond well to immunotherapy. And even up to today, we do not fully understand the factors leading to the significant immune suppression in the liver. There are questions of keeping the tumors, the immune cells out, metabolic reasons, but at the end of the day, we have not a solution because we do not know the etiology. So we talked about primary tumor location, and we talked now about the location of the metastatic disease, which is impacting when and how you should treat. Now, the first study leading to the approval of pembrolizumab for MSI-high colon cancer was Keynote 177. You remember that the patients were randomized to Pembro versus standard of care treatment. And you see on the left-hand side the PFS, and it looks like that in the first 3-4 months, the chemotherapy is better. And then there was a crossover. How is that possible? Well, it's possible because they were really not classified correctly. These were MSS tumors. And in Keynote, the endpoint was patients who had local testing were used for the analysis. When you take them out, the curves do not cross. So this is where you have an important impact to make sure the MSI testing is appropriate. Now, what is PFS2? And that's a new term we are starting to use in particular immuno-related clinical trials. So PFS2 is the disease progression of the subsequent treatment, so what patients get after the first line of treatment, or the start of the second subsequent treatment or death. What it means, it will show that maybe sequence matters, because you can see that pembrolizumab is significantly better than chemo. Even many patients in the chemo crossed over to immunotherapy. I think in Keynote was 60-some%. Yes. Mm-hmm. How is that possible? Well, we know from other cancers and other countries, when you do immunotherapy and you give chemo after immuno, you have higher success rate. Because immuno remodels and reprograms the tumor microenvironment, allowing higher efficacy of chemotherapy. So it matters when you give what. So whenever you have a chance to give immuno in this patient, start with immuno. Don't save it for later, because you're missing out on the major impact and the benefit of potential higher sensitive subsequent treatments. That was shown in gastric cancer in Japan. It's shown here. And this is becoming a novel understanding that with treatment, you enhance the sensitivity of subsequent treatments. This was the 5-year update, and you can see the survival, which was not the end point because people crossed over. It showed the overall significant impact for metastatic disease. Look at the chemo and the pembro arm. They're all about 50% after 5 years. That's amazing. Oh. And these patients have a high quality of life when they get immunotherapy. There is, of course, some issues you need to be aware of, because the best response with pembro was about 30% had progression of disease. We need to find innate resistance to nivo or pembro, it doesn't matter, because we don't know, because nivo looks very similar. Now nivo-ipi looks different, and we get to that. So we need to better figure out who will have innate resistance, but at the same time, who will have a complete response with single-agent PD-L1 or PD-1, because then you may not need the CTLA-4. So we need the biomarkers for different reasons to treat or to combine it with other agents. And this kind of compares the efficacy of the PFS. You see the nivo-ipi all the way up, and then pembro, and then the chemo arms in the both randomized phase 3, indicating that immunotherapy alone with a PD-1 is potentially not enough. The CTLA-4 combination seems to be more successful, and we all heard of the novel CTLA-4 antibodies. They're called masked, or they're called BOT/BAL, where they're Fc engineered, showing high efficacy even in MSS tumors for patients with extrahepatic disease. There is something very unique when you look at nivo-ipi, first and second line. The response rate is almost identical, because it doesn't matter when you give immuno, the efficacy is almost the same, PD-1 or the PD-1 combination with CTLA-4. But you need to give it as soon as possible because you impact subsequent treatments. There is no acquired resistance over lines of treatment to immuno, but the subsequent treatments may completely differ. So let me tell you a little bit about Checkmate 8HW. Randomized phase 3 studies, 839 patients randomized to nivo alone, nivo-ipi, or chemotherapy. And this was the progression-free survival comparing nivo-ipi versus chemo. Hazard ratio of 0.21. We don't usually see a benefit in 79% reduction of risk of dying or progression. Becky, we're sitting here in the front. Okay, so this is incredible. Oh, so this is really considered a new standard of care, and it's now approved globally in the US, in EU, in Australia, in China. So this has to be a first-line treatment option. And this is the PFS2 again. And you can see here that the sequence matters. When you give first immuno and then chemo versus first chemo and then immuno, it makes a difference. So do it at the time, at the diagnosis when you have MSI status. I think the side effects, obviously, with chemo are much more than with immuno. You have a typical immune-related side effects, and I'll let Sarah talk about it in more detail. Liver mets didn't matter. Okay? For MSI high, we don't care. Now, this was newly presented today because this is the Nivo-Ipi versus Nivo. Because the big question in the room was, there was never a comparison between Nivo and Ipi versus Nivo. And it's clear that Nivo-Ipi is better with a hazard ratio of 0.62. So a 38% reduction of risk of progression and death. It is a more effective treatment. And this is PFS2. It continues in the subsequent treatment. So the combination also ensures more benefit in subsequent chemotherapy treatments. Nivo-Ipi has also a significant higher response rate with 71% versus 58%. Interestingly, the complete response is very similar, 30 and 28. So if we know the 28 who have a complete response with Nivo, we may not need the CTLA-4. This goes along with very improvement of quality of life. After week 21, there is a separation of these curves. This is a study pending in first line. Here it is atezo plus minus bev with chemo in the MSI high. We have not today data yet. I'm not sure when we get it, probably a year or so. So let's go back to our patient, James, the 57-year-old who had newly diagnosed right-sided colon cancer with liver mets. You can see that James expressed interest to be getting aggressive treatment. The biopsy was done, and loss of MLH1 and PMS2 was seen. And following a multidisciplinary tumor board, James found to have also wild-type KRAS and BRAF, no HER2 amplification, and MSI high was confirmed by NGS. So this is the second poll question. Given James' presentation and preferences, how would you approach treatment selection? Is he eligible for upfront immunotherapy? What factors from the decision to use dual blockade versus PD-1 monotherapy? Okay, here you go. Please vote.
Do you like standing up there? I've never done that.
You give them 6 minutes to vote? No. Should be. Oh, here we go. Oh. Okay. I think we can have our second drink. The majority of you choose Nivo-Ipi. This is probably the best treatment option this patient would have. Any thoughts, Sarah?
Well, I would have voted for sure Nivo-Ipi, I have to say. And your question, and also actually a question I have here in the iPad,
okay.
It's how to choose between monotherapy and combination. Obviously, we had multiple choice. Pembrolizumab monotherapy, it's okay. Nivolumab monotherapy, it's okay. Dostarlimab may be more, I would choose in a rectal cancer, probably in another setting, and Katie will tell us in a few minutes. But I think that actually we don't know how to choose between monotherapy and a doublet. And for now, I have to say that for me, Nivo plus Ipi is my first choice for every patient, because this magic biomarker to identify the patient that are having a complete response with nivolumab monotherapy, we don't have it.
Will not happen, yeah, I agree.
And so actually, for me, only reason to treat with the monotherapy is when I have a mild contraindication, like, patient with a previous history of an EBD, an inflammatory bowel disease, super well controlled, no corticosteroid, but that he had in the past. And so I don't want to miss the opportunity to treat him with immune therapy, but also I don't want to risk to reactivate colitis.
Yeah,
and so I choose for nivolumab because we will see that it's ipilimumab adding more risk. But I think that they are very, very specific patient population.
Yeah. No, but it's a good
I don't
point.
think that the majority of the patient really don't have problem with the doublet and can have some gain.
Yeah, no, that makes a lot of sense. I would choose the same. Anyone who had some autoimmune disorders, I would not do a CTL4. Because there is higher risk of some of the longer lasting and non-reversible side effects. There is actually very interesting questions, and maybe, Kathy, you can help. So insights on using AI in therapy decisions. Is Vanderbilt using AI in treatment decisions?
Not necessarily in treatment decisions, but there's a lot of use in AI currently at our institution, specifically in regards to research opportunities, especially with large databases and basically looking at drug resistance.
Yeah. So I tell you an interesting story for AI. A company, not a pharmaceutical and not a biotech, approached us. There were engineers and computer scientists who had access to large databases of different cancers and identified targets, identified in situ drugs, and came up with a drug which says it should work in cancer. They said, we don't know how to do it because we are not in the clinical development. We looked and worked with them, wrote a protocol. It seemed that this target was particularly interested in HCC. We started a phase 1 trial, so no pharmaceutical industry involved. The third patient enrolled had a PR. I think AI will be incredible revolutionizing drug development and accelerating drug development, because all the toxicities, all the dosing, all the potential off-target effects can be now screened very effectively. So I think AI is not part of the treatment decision, but it can certainly help in risk stratification in patient population and align patients to better treatment. We have not that in place, we just talked about it. And there was one question about TMB. So maybe, Sarah, you want to talk about how important TMB is?
Well, this is a tricky question because I think that we still have to learn a lot about TMB in the MSS population, because you know that we have like a cutoff of 10 that is like a magical number, because we really don't know if the 10 mutation per megabase is really a number that is sufficient in every disease. And actually, we know that in colon cancer is not working so well. Yeah. And I want to treat now a patient with 10, 11, 12, an MSS, obviously, patient with immune therapy. I don't think that we are there now. Maybe with a combination of immune therapy and chemotherapy, I would like to do. Probably a reasonable cutoff in colon cancer is 20. And then we need to know also that there are other mutations like POLE, POLD1 that have super high TMB. They are not MSI, but the concept is very similar because you have a defect in repairing the DNA. And so I think that we still have to learn a lot on TMB. It's something that we look at, but it's not the first driver of my choice, I would say. And also we have to remember that if we have an MSI, we don't care about the TMB.
Right.
Because they are superimposed more or less always. And so it's not something that I do routinely, I have to say.
Okay.
And then I think it's important to keep in mind the original keynote study that resulted in the approval did not have any colon cancer patients
Yes.
on the study. And there was actually a recent paper that came out this year. They looked at high TMB and they gave them IO therapy and MSI stable versus utilizing Rigo or TAS-102. And the patients that received TAS-102 or Rigo actually did better than the patients that received IO.
So I think the MSS TMB don't exist even, and Kathy is correct, the TMB of over 10, MSS colon cancer, no one responded, were not included.
Yeah. No.
There are some interesting data for MSI high that TMB of 35 or 40 have a much better response, but that's also very early. Okay, now, whenever you see a TMB of 100, Sarah mentioned that, and no MSI high, that's a pole E or D mutation.
Yeah.
Just don't disqualify it. Okay, I think I will go quickly through it because I made that point already. When you use immunotherapy in any lines, the efficacy remains very similar high. There is no acquired resistance with previous treatments. So, let's go to the resectable local advanced. Kathy,
I have to get down here because I'm too short. So
Okay.
I think I have my own thing.
You can go, you
Okay,
can go.
so I don't usually do this Vanna White thing, so we'll see how this goes. I see you pacing back and forth. I'm quite impressed. So I'm just going to stand here because I am incredibly short and I did not wear heels today because it's been a long day, so I apologize. So I'm going to be discussing kind of where we are currently with neoadjuvant therapy in our early stage patient population. It's a hot topic. Is there a role in this patient population that's theoretically curable already? And in some settings, we would normally just take them to surgery. Oh, I have to stand up closer because I can't see. Now I know why you're standing up here. Okay, and also because I have new progressives, so don't let me fall off the stage. So this is exactly what Heinz was referring to, which we find a bit perplexing. So this is all in the NCCN guidelines. And so basically, I'm going to take these off, I apologize. So it's very complicated just by looking at this. And we were surprised. Many of these drugs, when you're going to, the left side, resectable, non-obstructing, historically, as mentioned here, they would consider going colectomy with removal of regional lymph nodes. Obviously, obstructing is a completely different story, and patients should see their surgeon immediately and have that addressed. But then you have your T4 disease, which is really right now a very hot topic. We have some clinical trials that are under development and where they're addressing this issue. And there are several of these IO therapies that are listed here, but some of them have never even been tested in colorectal cancer, as far as I'm aware. Maybe some pilot projects, but nothing in a phase 3 trial. And then you have the new addition of nivo-ipi, which, as mentioned earlier, we were once again a little surprised about, because historically we don't commonly give combined IO therapy after you've just had an IO failure as a single agent. But clearly there's ongoing data. And we always want to emphasize at the top, which is in purple, please, please, please enroll to a clinical trial. We cannot make advances in our field without clinical trial enrollment. So it's of key importance to please enroll for a clinical trial. And obviously, there's a lot of discussion. If you've had a great response, if you had a complete response, is this very similar to rectal cancer? Are you really not going to go to surgery? Is this something your surgical colleagues would feel comfortable with, off protocol? And we were discussing that because currently all the clinical trials involve subsequent colonoscopies if you're talking about colon cancer. This is not like a flex-sig for rectal cancer where it's very easy to evaluate. When it's for colon cancer, to evaluate the primary tumor, you're going to have to do a colonoscopy. Is this something insurance companies are going to pay for? So once again, please enroll to clinical trials so we can get these answers. So the really big hot topic is what's going to be part of the plenary session, which Heinz alluded to earlier, which is the ATOMIC trial, which is specifically in our deficient MMR patient population in our colon cancer patients. So instead of giving sending them straight to surgery. Are these patients benefiting from IO therapy? So as you can see here is the clinical study design. It was specifically for stage 3 patients, and they had to be confirmed deficient in MMR. They were randomized to chemotherapy. At that time, this trial is quite old, so that I don't even remember how many years. Yeah. Probably 10 years.
About.
And so that's why it says 12 cycles of FOLFOX. As we all know, sometimes we only give 3 months, sorry, and then FOLFOX plus atezolizumab for 12 cycles. And I think that was an FDA mandate, if I recall correctly. So this is the plenary session. If you want to see what is the role for IO therapy in stage 3 deficient MMR patients.
And it has to be positive, otherwise it wouldn't be in the plenary. Or,
Yeah.
You never know.
But very rarely negative.
Yeah, I think it's going to be positive. We don't know the data. Primary endpoint is disease-free survival. I think we've all seen the data in rectal cancer. It was the front of the New York Times. It was being run by our lovely friend Andrea Sursek, which was a single institution study looking at dostarlimab, specifically in locally advanced rectal carcinoma patient population, where it gave the patients the option of organ preservation and also allowed them to avoid radiation therapy because the results were quite spectacular. So this required dostarlimab, though, for 6 months. Keep in mind, this is single-agent IO therapy. Patients were evaluated for a clinical CR with a multidisciplinary effort. If you're going to consider this type of approach, you have to have multi-D effort with your surgical colleagues engaged, because you have to evaluate the patients for disease as well as adequate diagnostic imaging. And the primary endpoint for this study was overall response rate. And I think everybody has seen these results. It's been presented 2 times now, now there's increased follow-up. We have a median follow-up of 26 months, and they continue to report a clinical complete response of 100%. Now, this was a single institution study. It was a small patient population. Originally, they have enrolled more patients. Since then, we have not seen further results, but currently, when they presented this last year, it was 48 patients, and I'm going to show you the current trial that they're validating those results, which is a multi-institutional study. Now, what about, we just talked about dostarlimab as a single agent, and then we just talked about the benefit potentially of early stage colon carcinoma. What other agents have been evaluated, and what other trials have been reported? I think some of you have seen this. This was also in New England Journal of Medicine from Miriam Chalabi, looking at neoadjuvant Nivo/Ipi. So dostarlimab in rectal cancer was for 6 months. This is for early stage colon cancer. You had to have T3 or T4 or node-positive disease. This was 1 dose of Nivo/Ipi, followed by a 2nd dose of Nivo, and all these patients went to surgery. So this is pathologic response. And what they noted is if you had a pathologic response, it was basically at least less than 50% residual tumor, obviously complete response standard. And the major pathologic response was less than 10% viable tumor. And this was the pathologic tumor regression based upon the tumor specimen. So they called it the Chalabi plot that day, if I recall. So basically, 98% had some type of pathologic response, and then complete response was noted in 68% of patients. Once again, Nivo/Ipi for 1 dose, followed by Nivo. But all those patients went to surgery, so it's a little different from the rectal cancer studies. She also looked at the role of anti-LAG3, so relatlimab, because there appears to be a potential increased benefit from utilizing a LAG3 due to T-cell exhaustion. Once again, similar schedule, Nivo, relatlimab, 1 dose, followed by another dose of Nivo. All the patients went to surgery once again, same patient population, T3, T4, node-positive patients. Once again, this was very similar, as you can see here, significant tumor regression plot. It was like 95% of patients had a pathologic response. And then in regards to complete clinical response, once again, 68% once again. She also looked at circulating tumor DNA as well, and that was she had after a long-term follow-up of the other study, so after 3 years, it was 100% disease-free survival. Now, what about other agents? As Heinz mentioned earlier, there are unique other agents that are not kind of our standard CTLA-4. There's a lot of interest in botensilimab, which is an enhanced CTLA-4 agent, basically, which is to improve, it has increased T-cell engagement. And so basically, this is looking at a small study of NEST-1 and NEST-2. This was in proficient patients as well as deficient patients. And basically, NEST-1 also did 2 doses of bot-bal, followed by an additional dose of balstilimab, which is the PD-1. And the NEST-2 did bot-bal for 1 dose, and then they did 4 doses total of balstilimab, which is the IO therapy, the PD-1. And as you can see here, once again, smaller number of patients evaluated, but significant response in both our proficient and deficient patient population. The Italian group, Gano, also looked at this in a larger cohort of patients, and as you can see here, also some very interesting data looking once again in our early stage colon cancer patients and how there may be benefit for utilizing neoadjuvant bot-bal. So what studies exist? And this was a very, very nice table that was put together by our colleagues here at Peer Review. These are retrospective studies, a small number of patients, as you can see here. But when looking at the neoadjuvant setting for colorectal carcinoma, you can see a significant pathologic response. As mentioned earlier, specifically for rectal carcinoma, there's another study from Wang and colleagues that looked at 29 patients, and they reported an 83% significant response as well, clinical response. So that obviously the role of IO therapy in rectal cancer is really of great interest for our deficient MMR patient population. And then in regards to our patient population, as mentioned earlier with the niche 2 and then niche 3, there's a lot of interesting studies that are currently ongoing for our patient population in this setting. So what studies are currently open? So AZURE-1 is validating the MSK data that was originally presented by Dr. Sursek. They have enrolled 150 plus patients, I think 154. This is completed enrollment. We do not have those results. So once again, this is dostarlimab for 9 cycles, which is roughly 6 months, and the same approach really to validate the data from MSK. So we're hoping that to evaluate the patients for a clinical CR, and then they would proceed with the non-operative management. If it's less than a clinical CR, patients go on to standard treatment involving surgical resection and radiation therapy if needed. AZURE-2 is looking at dostarlimab in the resectable colon patient population. So now, once again, T4 patients, stage 3 patients, node-positive patients. So dostarlimab for 4 cycles, you go on to surgery, and then you receive the remaining of your dostarlimab versus going to surgery followed by adjuvant chemotherapy. So this trial, I do not think it's completed enrollment yet, and this is an international study. Okay, so we're going to ask you this question. Which of the following accurately describes patients who are eligible to enroll in the phase 3 AZURE-2 trial evaluating the efficacy of dostarlimab? So it is in the patient population for rectal cancer? Is it in the patient population for colon carcinoma? Is it the unresectable rectal carcinoma patient population? Or is it the unresectable stage 3 or T4 or deficient MMR colon carcinoma patients? It's making it quite complicated by those answers. I didn't make up this question, so I just want to be honest.
It's her fault, okay? Actually, I have some interesting questions here on the...
Yeah.
Because it is confusing between AZURE-1 and AZURE-2.
Yeah.
Oh, wow.
Well, so Well, that's pretty much the right answer.
Yeah.
Yeah, so 48%, so half of you got the answer correct. It's specifically in colon carcinoma. I know it's kind of hard. How would you know? Is there one is rectal, is there two is colon? But that's they decided to do it from the bottom up, and in part it's because Dr. Sursek is running both of those trials, and obviously her original interest was in the rectal cancer patient population.
Okay, there is one question which would fit your presentation, which says, do rectal carcinomas in the proximal 1/3 of the rectum need another management than carcinoma in the distal third?
Do they need different management?
Yes.
Or
another.
Oh, that's fair. So I'm presuming an MSI stable patient population.
It doesn't say, but yeah, I assume.
Yes. So there was a trial called Prospect that did look at the upper rectal for a large phase 3 clinical trial, looked at the role of omitting radiation therapy altogether. Now, this is not a IO-based trial, but it was looking at neoadjuvant FOLFOX or oxaliplatin-based therapy. And if you had greater than 20% response and you had a high-lying rectal cancer tumor, you were able to omit radiation therapy. I think that's what they're referring to.
I think the biggest point is in the distal rectal, you may lose or need a stoma. And when you have a really good clinical response, you may do watch and wait and save or you don't need a surgery or radiation, which have significant side effects. In the high rectal, you may get along with a LAR without having major quality of life issues. So that is the major difference in the approach, where you potentially circumvent or allow a sphincter saving surgery.
And then also, I mean, the data from Oprah suggested for the very low-lying tumors, you do chemoradiation therapy first.
Yes.
Versus the opposite sequence to improve your chance of sphincter preservation. So it's hard to interpret which way they meant the question.
No,
yes.
I understand. It's okay. It's okay. Where is the future heading for IO in locally advanced disease? What evidence is needed to better support IO in this setting?
Yeah, I think that basically these trials are really key to demonstrating the benefit of IO in the earlier stage setting. We're waiting, obviously, these are AZUR-1, AZUR-2 are specifically with dostarlimab as a single agent. However, obviously, I think the data regarding the other drugs, BOT/BAL, the fact you only needed to give a couple of doses of treatment in combination, I think is really, really important. The other thing to keep in mind, as mentioned earlier, colon carcinoma, with all the prior studies, these patients went on to surgery. And I think the field is, now the question is, can we get our surgical colleagues to work with us, and can we potentially defer surgical resection? I think that's another issue, and we still don't know the duration, basically. That's what I'm alluding to.
So I'm a little bit more optimistic. Oh, of course, Sarah.
Can I make a comment on that? I think that one thing that it's important to be underlined is that obviously the whole body of evidence altogether are saying that there's a role for neoadjuvant immune checkpoint in the MSI-high. Mm-hmm. But also we have to consider what Heinz told us about the super good prognosis we have in those patients in the earlier setting, because, actually NICHE-2 is amazing, 100% of a patient without relapse at 3 years. That's fantastic. But don't think that we are comparing with 60% of a patient relapsing, because I think that in this kind of population enrolled in the NICHE-2 MSI-high, with surgery alone, it's 85 to 90% of disease-free at 3 years.
Yeah.
And so, okay, we have 100 against 85, 90. That's amazing anyway, but we are not facing patients. And so the concern about how to stage them, that is a big problem, and even bigger in the MSI-high, as you said. And the fact that the majority of them are cured with the surgery alone. And so I think that's why I like that there is the AZUR-2 ongoing, because I think that it will be able to give us a precise estimation of the benefit of giving them neoadjuvant immune therapy.
Yeah. So I think I'm probably more the optimist. I think that in 5 to 10 years, we treat all locally advanced rectal and colon cancer with immunotherapy, independent of MSI high or MSS. Because when you look at the involvement of the immunotherapies, we have now 40% response rate in MSS extrahepatic disease. So we're talking about not metastatic disease. Obviously, the treatment should be more effective. With the new development, engineered antibodies and novel combinations, I think what will happen, we will treat them all. I think I agree with you, staging for colon is complicated, but we will figure that out somehow. We treat them for, and that's the problem, do we treat them for 6 weeks or 3 months, and then we decide if we need surgery. And then, if they need surgery, we decide if we need adjuvant treatment. With this approach, we will have less surgery, not zero, and less adjuvant treatment because of the success. We will go there, and that's a good thing.
I think it's exciting, though, to not have to undergo standard chemotherapy.
So what I'm saying is I don't think it will go away, but we may need less and less surgery and classical chemo. So I think we are on the right way for that, but it takes time. There is a lot of logistics.
We still don't have all the elements to go there.
Yeah.
Okay.
There are a couple of questions from the floor.
Oh, sorry.
The original data regarding the data of dostarlimab from MD Anderson.
MSK.
MSK.
Not MD Anderson.
It was about Lynch syndrome in rectal cancer. And
Right.
here I see you are having colorectal cancer, the discussion about colorectal cancer and MMR deficient, not Lynch syndrome. Can you elaborate on that?
So there is no difference if you have a somatic MSI high or you have a Lynch syndrome for the response of immunotherapy.
Right.
Okay, so they have both these MSI in the tumor and respond to it. So there is no difference. Lynch syndrome versus a somatic MSI high tumors are not treated differently. The benefit and the outcome is the same.
Yeah, they looked at the data from Keynote, if I recall, from the Keynote 177, the metastatic setting. There was no difference in the outcomes.
Checkmate the same.
Yeah, between the Lynch patients and the hypermethylators.
There was some hint in one of the studies, I don't know, where maybe Lynch differently, but that was not confirmed in the phase 3s.
There is an ongoing trial called CMARC, which is looking specifically at your hypermethylators and IO therapy. But that data is not out yet.
Okay, Michaela.
If a patient that undergoes surgery and has MSI tumors, stage 3 with high risk, what would
MSI high?
MSI high, yes. What would you do as adjuvant therapy?
Yes, what would you do, Kathy and Sarah?
We don't give 5-FU.
No, this is stage 3.
Yeah.
Stage 3.
Stage 3, you
So
have to give...
Let's see after Sunday.
That's what we're going to find out from the atomic trial.
See after the plenary.
Yeah. So I think we will know the answer after the
Yeah.
plenary, okay? But usually in stage 3, MSI is not predictive and prognostic. You would give chemo, but that may change on, what is it, on Sunday?
It's on Sunday. But historically, there's data that shows don't ever give them single agent 5-FU-based therapy, and that was the whole
Exactly.
premise of why Atomic was created, because we knew 5-FU-based therapy was problematic.
Okay.
So just real quick, there's an ongoing study I think that's very interesting in combination with chemotherapy in MSI-stable patients. This is not being conducted in the United States. It is being conducted in Europe by Sabine Tejpar. This trial has, I think, opened at some sites, and it's a 3-to-1 randomization of Capox and dostarlimab in the MSI-stable patient population versus Capox alone going on to surgery, and then several correlatives are going to be collected, and the primary endpoint here is major pathologic response. So I think that's actually a very interesting study. Also, in Europe, once again, there's also various combinations of BOT/BAL in various malignancies, upper GI, gyne-onc, just so you are aware, these are trials that are ongoing that I think we'll be looking forward to those results, and that's the neo-ASIS study. So I don't think we have time for this.
No, let's skip that.
Yeah.
Because these guys want to have their drink. Skip
Okay.
this one. Let's go to Sarah. Sorry about that.
No worries.
I know you want to also go home.
So, we've heard a lot of amazing data on immunotherapy. But when colleagues in the melanoma and in lung cancer started to use immune therapy, this was a nice editorial at the beginning of the immunotherapy story, saying that probably autoimmunity was the Achilles heel of cancer immunotherapy, and there was a lot of worry about autoimmune disease in people treated with immune therapy. But at the same time, we started to add some data that are maybe not so solid, but that sometimes if you have an immune-related adverse event, this is a patient that is responding very quickly and very intensively to the treatment and can also have more benefit. And so it was really not clear if it was so bad to have immune-related adverse event. As you know, they can happen more or less everywhere because clearly they are linked to an overstimulation of our immune system. And so mainly, basically every organ can be recognized by our immune system and developed an autoimmune adverse event. Clearly, the more frequent are the endocrine symptoms, the skin changes, as you can see in this table, colitis, pneumonitis, hepatitis. But a lot of these adverse events are mainly recognized by blood sample examination, and they have not a clinical course impacting really on the patient. But in a small proportion of them can happen. And clearly, you can see here, these are the most common, and you can see the blue bars that are related to the combination between ipilimumab and nivolumab. One caveat is that all the initial data on the combo were observed when we used 3 milligrams for ipilimumab and 1 milligram for nivolumab. This is not the dose we are using in colon cancer, because we are using 3 milligrams for nivolumab and 1 milligram per kilo for ipilimumab. And also we are using only 4 doses of ipilimumab. Like it's a priming of the response, because the anti-CTLA-4 is a synergic, obviously, and is working at the beginning when you have to trigger the immune response. But then probably you don't need it anymore, and so we have only 4 doses and then nivolumab monotherapy. And so I don't recognize what I'm seeing now in the MSI-high colorectal cancer. In this picture, that is a very classical picture. You can see it more or less everywhere, or similar one. But it's not really what we are seeing now in our clinic. And another important point is the time of onset and the duration of the immune-related adverse event. And you can see here that the only one that is long-lasting is endocrinopathy. Clearly, if you have an immune-related endocrinopathy, the patient has to receive a substitution, depending obviously of the kind of endocrinopathy, for all the rest of his life. And so this is something we don't want to see. For all the others, obviously, we don't want to see nothing. But, as you can see in this picture, all the other adverse events usually recover quite quickly if they are properly treated. And another important point, Heinz shows already the data of the quality of the of life data of the CheckMate 8HW. This is a similar graph from the CheckMate 142. One important thing is the treatment in the MSI-high population is so active that the improvement in symptoms, the tumor response, completely overcome the impact of the adverse event. Because we saw in every data of colon cancer MSI-high treated with immune therapy, we saw kind of this kind of graph with an improvement of quality of life. And so this is also related to the fact that some adverse events are subclinical. We see them in the numbers of our blood examination, but actually patients are not really feeling them. And so let's say now that we have this patient that has to receive nivolumab and ipilimumab, and we have to explain him what can happen receiving this treatment, that it's different from the other treatment, probably his aunt or his friend, his neighbor received before. You know, I think that also your patient every time says, oh, they have colon cancer, they say, my aunt has a breast cancer, she lost all the hair. Okay, we are doing another thing. And so it's important how we explain to the patient the treatment.
No,
It's not working anymore?
No, they can forward it.
We're going to do a poll.
They're doing a poll question now. So here, oh,
No,
What happened to the poll?
no polling question. Maybe it's later.
usually it should come. Otherwise we skip it, it's not a...
Yes.
Oh, here it is.
Oh, okay, okay.
Perfect.
No, clearly they don't resolve by their own, and we are gonna see after what we have to say to our patient and what we have to prescribe to them. And yes, second one, I also think that the most important thing is to tell them to report everything. And also we have to consider that sometimes the patient, when he's sick, he don't come to us. If maybe he go to a general practitioner or an emergency room if is really heavily sick. And so it's important that they know that have to report what are they receiving, because actually otherwise, if a patient has diarrhea, probably our colleague will prescribe loperamide, and for sure, because you are expecting, oh, I'm receiving a cancer treatment, and so first thought is, okay, he's receiving chemotherapy, I give him loperamide. And so they need to know that they have to specify that they are not receiving a chemotherapy, but they are receiving an immune therapy. And that's why we have this kind of circle starting from prevention, anticipating, and obviously detect what is happening, and then treat and monitor. And if this is a positive circle, if we always have in mind every step of the management, and we don't have to underestimate even the grade 1. We have to monitor very closely, and if we have a grade 2 toxicity, maybe we have to stop for a while treatment, understand what is happening, and start corticosteroid, and see if the symptoms are improving rapidly. And then clearly, if we have a grade 3 or 4 with a severe toxicity, we need to be very aggressive in treating with the corticosteroid, and not only corticosteroid, but also immune suppressive drug like infliximab and mycophenolate. And here you can see a list of drugs that we used commonly. In Italy, we use obviously corticosteroid, and then we use infliximab and mycophenolic acid. Tocilizumab and vedolizumab are off-label in Italy, and so it's more difficult to have them, but sometimes we prescribe them. Another point we need to have in mind is also that we have some circumstances that can be confounding or can impact, like obviously if you have an heavily smoker, his lungs are not clean and perfect, and so it's not always easy to catch at the beginning a pneumonitis, an immune-related pneumonitis in a lung of an heavy smoker, obviously, and also is more sensitive to this kind of event. And obviously, we already mentioned all the autoimmune disease that can be present in the history of the patient. Some points are, to me, very important to be specified. First of all, we now have sufficient data to say that if we use corticosteroid for toxicity, we are not impairing efficacy. This is important because at the beginning, it's, oh no, I don't want to use them, I want to wait, let's see what's happened, because if I use corticosteroid, I'm impairing efficacy. This is not true. Providing that we use corticosteroid when they are needed, obviously, and also that we try to taper them as soon as possible. If you have a rapid response to corticosteroid, it's really not needed to go on and go on. You can, when you have a grade 1 or complete resolution, depending on the symptoms, obviously, you can start to taper the corticosteroid. And if you do this, you are not negatively impacting on the recovery from the adverse event, and also you are not impacting on efficacy of immune therapy. And another question is, if I have an immune-related adverse event and then I have a resolution, can I recover immunotherapy? It depends on the severity of the immune-related adverse event, clearly, because if you had like a grade 2, you start the corticosteroid and you have a rapid resolution and you are able to taper all the corticosteroid, you can consider to resume immune therapy. But if you had grade 3 or grade 4 toxicity, or a long-lasting grade 2 without a rapid response to corticosteroid, you weren't able to de-escalate rapidly the corticosteroid, clearly immune therapy reintroduction is not advised. And also another point is that it makes no sense to reduce the dose. There are not dose reduction of immune therapy, clearly. But one nice point to keep in mind is that we saw, these are Checkmate 142 data, that in patient interrupting treatment, and in this trial, most of them interrupted due to toxicity, they were treatment-free this was a really long follow-up, 52 months of median follow-up. And so if a patient is in a complete or partial response and you have to stop treatment due to toxicity, you have good probability that the patient stay in this good response. And so we don't have to be too much afraid of withdrawing immune therapy in these patients. So just to close very, very quickly, coming back to a patient presenting with sickle CRC metastatic to the liver, loss of MLH1 and PMS2, and so the MMR. He received an upfront immune therapy regimen, let's say with a combination, Nivo plus Ipi, and then he had diarrhea, 4 to 6 stools above the baseline, and so it's a grade 2. How to manage this kind of patients? What are you doing in your practice for a grade 2? And these are what you can see in the CT scan of and in the PET CT of a patient like this. They are a bit messed up, but you can see the first part on the left is you can see like a donut.
A donut.
A donut that is the thickening of the colon and pericolic fat that is positive also in the PET CT scan, and then you can see after the resolution. In this case, clearly we use steroid therapy, and if you are not able to resolve the colitis, you go for infliximab. That is the attitude in Italy and Europe. I don't know if it's the same for you.
I think it's the same. I think what we have learned is we are not waiting to a grade 3.
Right.
Yeah,
We are
exactly.
doing it with developing of a grade 1 and certainly grade 2. So earlier intervention with steroid infliximab will prevent the grade 3 and longer delays. So I think this is a very important thing which changed our management of this.
Yes, because if you start intervention very early, probably you will be able to control very quickly and then to taper.
Yeah.
And also we have to keep in mind that there are, for instance, also competitive causes of colitis. And so we need to exclude other interaction with drug, other infective causes of diarrhea, like Clostridium difficile. Fecal calprotectin can help sometimes because can help to discriminate the origin of the colitis. And clearly, if you are not able to really understand, start corticosteroid without waiting, and then you can consider to have an endoscopy to confirm the autoimmune origin of the colitis, but don't wait to start corticosteroid for having all this data. And just to close, remember that patient education and collaboration with colleagues with the multidisciplinary team is important, not only to decide the correct oncologic strategy for the patient, but also sometimes for managing this kind of tricky situation and to help us in supporting patient engagement, education, and so we need to be able to look at the patient from different perspectives with the help of our colleague. And so I think nothing new here, and I leave to you the conclusions.
Sure. So thank you very much for everyone who are coming. It's a Friday night in Chicago. I'm sure you have very nice places to go through. I would like to thank you for spending time. I hope the presentation by Sarah and Kathy and myself was helpful in order to really have a new insight on indication testing for MSI high or MSS and treatment options which have developed and changed the paradigm of our treatment armamentarium for colorectal cancer with MSI high. I think there is a revolution going on in the neoadjuvant setting for rectal cancer, for MSI for sure, maybe also for MSS. And the need for management of the immunotherapy-related side effects, I think Sarah gave an incredible overview what you have to watch out for. So thank you very much for coming tonight, and thank you everyone for spending time with us, and thank you for the great presentations, and have a wonderful time in Chicago and ASCO. And I know I apologize, I couldn't get to all these questions. If you have questions, just approach one of us. It's not a problem. But I'm sure you want to have a wonderful night out tonight. So see you at ASCO. Thank you very much.
Bye-bye.